Oh, there we go. Hi. Thanks for sticking around. I will try to match Liz's enthusiasm and energy as we go through, and actually it's a perfect dovetail. So I'm going to be talking about the use of tailoring algorithms, which are pre-programmed systems by which you can formalize content delivery in a way that is more personalized and managed. I was at a talk the other day and somebody said, dude, that's so 1990. So my hope is that at the end we'll talk about how we should be using machine learning and AI as a way of overcoming some of those challenges and keeping some of this work fresh. As a funding disclosure, I am a member of the ATN, the Adolescent Medicine Trials Network for HIV and AIDS Interventions. There are 3 of these networks currently. I work in the one that Lisa Haito-Whiteman is the captain, alongside Patrick Sullivan. And I just wanted to make sure that I mentioned that although Get Connected is up here, we actually, when we wrote the center grant or the network grant, we actually thought about the continuum and thought about not only individual level issues, but also structural considerations. So these are the, I think, 10 protocols that were funded through the network and currently being tested for either acceptability and or efficacy. And every dot means that there is content or activities related to some place in the continuum, whether they be for positives or negatives. So I'm going to talk about Get Connected. Get Connected is actually an adaptation of Project Connect Health Systems, which was an intervention, a school-based intervention, where we tried to get youth to link to appropriate care. And Vincent can say much more about this. It was worked on by Patty Dittis at CDC and others. And we were at CDC a few years ago, and it was a special convening meeting on how do we start thinking about STIs among MSM. And so from that work, we decided to take the basic elements and assumptions of Project Connect and perhaps using community-based participatory research and innovation and design thinking, put together an STI test motivation testing app that was then tested with young MSM 15 to 24 in Metro Detroit and Flint. And if you're from Michigan or have been in Michigan, you know that the mitten matters. So we're talking everywhere from Detroit up to Flint over to Ann Arbor, so the big triangle, which actually covers 75% of the population of the state of Michigan. We had both a youth advisory board and a practitioner advisory board. And in 2016, NASM actually came to Detroit thinking about digital strategies, and we got a gold star for being a case study of good participatory processes and how we could engage communities in building health. So thanks, NASM. So what is Get Connected? It's currently a web app. We did not go straight into a mobile phone app. These are I think the challenges and combinations of a randomized controlled trial versus something that can go straight to market. It's much easier to fix a bug if it's a web app that is mobile optimized than it is to have something already in the market site and then requires approval and consideration by both either Android or Apple, depending on who your manufacturer are. And in its basic formulation, it's really intending to help young MSM be motivated to test for HIV and STIs and then link them to high-performing sites. We have both content and images that are tailored as users create a profile. In this case, it would be a survey. And so you can see on the left-hand side, it includes important things like age, race, ethnicity, your sexual identity, and where you are in the coming out process, as well as some structural struggles, including residential instability, a history of incarceration, not having good medical care, having been kicked out, and not being able to use your parents' insurance if they have insurance, and so on. And there are 4 major buckets of content. The what is an STI test? Why should I get one? Why should I get tested? How do I do that? And then where? Okay, so pretty fundamental behavioral intervention work. And so this is Philly, my home. And you can see, if you look at hiv.gov or the CDC NPIN test locator, you can actually see that there are very different types of HIV and STI locations. Some of them are Riot White funding, some of them are comprehensive family planning, some of them are just HIV and STI. And so we've spent millions upon millions of dollars telling young people to be responsible, to do the right thing, to get tested frequently, but nobody's actually asking the crucial question, which is, are we sending them to the safe places they should be at? How do we actually know that all of our apps, all of our technologies, all of our resource directories, all of our funding is actually being used in a way that is affirming to young people, particularly queer and trans people? And so I started thinking long and hard about what this could look like in the app. And we thought, well, we could use Facebook reviews or Google reviews or Yelp reviews. But similar to that normal distribution curve that Liz talked about, Yelp reviews and Google reviews are known to be extremes. It's either somebody who got asked by the agency to write something nice about them, or someone who had a really bad experience. Not only that, it's not very systematic in how what feedback you're getting as a provider. And so, how do I go back? There we go. So we decided to fix that. And so as part of Get Connected, once you go through your own individual intrinsic motivators, we actually then match you based on your answers and rank the best sites that meet your needs. So for instance, if you say, I'm Jose, I just moved from Puerto Rico, I'm 19, I am still figuring out my sexuality, I want to go to an LGBT inclusive space, the app is actually going to rank sites that scored very high on not only racial and ethnic diversity, but also LGBT comprehensive care as perhaps the better place to go. And it'll tell them, it might be a little further away, but we took that into account. This is really where you should be going. In the pilot trial that we did in Detroit, we had a very limited follow-up window of 30 days because of funding constraints, but we actually found that a third of our sample of 100 young MSM, all high risk, had tested for HIV and STIs. We detected 1 new HIV case and 4 STIs that were treated, just in a 30-day period, right? So you can imagine the potential. But then this doesn't necessarily tell you how I did that. So let me tell you how I did that, and not only how we do that, but how we think about Get Connected as a multi-level intervention that not only intervenes on youth, but also on agencies. We actually train young people in each community to rank their experience getting tested. We use a mystery shopping approach, and we can talk at length about that. But here are some of the domains that we look at and that we add in the back end of the application. We actually don't list the agency scores anywhere, although agencies will get their results, and I'll show you what that looks like. But we do use that for the matching and the rank sorting of agencies. So why mystery shopping? In public health, we've actually been really good about using and borrowing from marketing strategies to think about community health initiatives. So we've used this to think about mom and pop shops and who's selling cigarettes and alcohol to minors. We've used it globally to think about provision of Plan B services and who gets access in a pharmacy, over the counter or not, as well as the provision of psychiatric services. And so we got really interested in thinking about, the advisory board, both the youth and the providers, on could we actually create expert assessors, young people who are going in and actually being treated like a young person in these agencies. And so we train them on best practices for counseling, testing, and referral, and then ask them to fill out a 48-item screener on quality improvement and quality control based on their testing experience. These are the assessments. We've actually now done the reliability and validity for the measurement. There's usually 3 to 5 items per domain. I'm happy to show you where that's published. But you can see here that it includes not just the provider. I think that's a really missed opportunity. We usually think that the provider is who needs training. What we actually learned was that clinic wait staff, waiting room staff, the nurses, the tech, the lab attendees, they actually are part of the system, and nobody has been just figuring out how they've been talking to each other. I'll give you a quick anecdote. One of our shoppers went to get tested, got a rapid test, got a urine test and a blood draw, and as he was leaving, he heard the waiting room attendant ask the head nurse, "So was he positive?" in front of an entire room, right? There is no reason for that question to be asked. There is no reason for the curiosity. But the person left basically thinking like, oh, man, I'd never come back here, right? I feel really ashamed. So it goes to this issue on stigma. We have tried to do some prevalence estimates at the site level. So each shopper goes at random days and times, and we make sure that there's at least 2 visits per each agency identified. This is data from Metro Detroit. There's 46 HIV STI clinics. 60% of the sites had at least 1 shopper have a provider that offered them risk reduction optioning. Only 40% of sites offered to set action steps to meet safer sex goals anywhere in the visit, and only 20% asked about condoms and lube. And if you know the mechanics of MSM behavior, you know that condoms will go nowhere without good lube. So I have to do the plug on the lube. Perhaps the story helps put this in context. This was a public health department where somebody went to get HIV and STI screening, and I'll read it for those of you in the back. Initially, the nurse practitioner appeared friendly and well-meaning. She told me about the different options and testing procedures that were available to me. When I refused to do the penile swab, she replied, quote, "Our clients don't have the option to pick and choose which test they can or cannot do. I told her, none here. If you don't do the penile swab, then I can't offer you any other test." When I still refused, she replied that this was a simple painless procedure and that it would only take a few seconds. She seemed almost disappointed that she had not intimidated me into doing the penile swab. So then she did the rapid HIV test and did not explain anonymity or confidentiality. Mind you, Michigan is a HIV criminalization state. She asked me to wait outside and didn't do any more counseling for me. She seemed really disappointed that my results were not what she expected. She said, quote, "With your history, I was certain you'd be positive, but you seem to be negative. I'm gonna give you some condoms, use them every time for sex." And they came in a little, what he called the doggy bag, like a paper bag that had a label that said the no nonsense kit. Overall, this was the worst testing site where my autonomy was taken away, and I was denied services because I refused to toe the line. This isn't a site that should be avoided for its unethical approaches and for being unapproachable to clients. This is definitely a site that should be avoided in its entirety. Guess what grade we gave them? No. Right? A big fat F. We have now replicated the same process. There's a paper forthcoming in JADES where we have looked at HIV testing locations that allegedly say they do rapid HIV testing. You can see that in each region, we've identified 50 to 55 locations, but then when you start breaking that down into availability of walk-in appointments and actual free testing, that number dwindles dramatically. So there is a continuum cascade also happening at the agency level that we need to be thinking about. And this is just a standardized on a 0 to 100 scale, each of the domains across the regions, and you can see that we're not really performing very well in any single domain. So I say this, and I decided to use Get Connected as an example because I think when we think about innovation, we want to go into e-health so desperately, right? We know that young people in particular really want to be online. And I get that, but in thinking about ending the epidemic, you know, the pillars exist under the foundation of a healthy HIV health force. And I think the same should be true for an STI health force. And so beyond these individual level change efforts, I think there is a way of marrying through technology the structural arguments we heard this morning with the behavioral arguments we heard in the afternoon, and really start using and leveraging public health informatics to support not only behavior change at the client level, but also quality assurance improvements at the agency and community level. Sean can talk to you about the HIV dashboard he's been building using social media. Later on, we have started trying to do something similar, but more private to the agency level. I'd love to think about this as a dashboard, but the health department has been quite hesitant to do that. So instead, what we do is we actually give the agencies, we mail them a letter with their reports. You say, you test people, we tested you. This is what we did. That's actually unfair. They can opt out of the mystery shopping if they so wanted, but nobody has except for 2 hospitals that just thought it would be a burden. And it really does go like through a cycle of bereavement. It goes from denial, that can't be the results from here, because we also give them their qualitative narrative from the shoppers, to who else knows about this? Is this gonna affect my funding? And we always say no. In fact, this is for technical assistance and capacity building. Let's go through it. And then there is an eagerness to want to use this. And I can't tell you the number of agencies who said, so in my next FOA, can I write in the RFA, the University of Michigan, or originally or now Penn, did this assessment in partnership with CHOP or Baylor or Emory, and we found that we're really great at patient counseling, but we're really bad at youth friendliness, so we're putting some money into it, right? So it can have some really helpful ways for that to happen. This is an example of, this is fake data, just so you know, but an example of what it would look like. There's actually 4 pages that reports the site score relative to the regional score, and then it gives them an infographic and at the end and some qualitative quotes. And so as we think about the end, I think to make prevention work, I think we need to start thinking about multi-level approaches. Technology is a way by which we can reconcile those in ways that we create feedback loops that are sustainable and that provide some way of moving forward. But I think that will require us to do several things, and I'll leave these up for your consideration. And particularly, we just finished an intervention that is getting published in Adolescent Health allegedly next week, called the Health Access Initiative. It was funded through CARS at CDC. And it's an agency level intervention where everybody has to present and be present on LGBT cultural competency. So there's much to do, and I really appreciate being invited. And with that, I will finish. Thank you.